We are 19 of us already, so I think it would be good to. Yes, so very good evening, all of you. Welcome to our first webinar of a series. And to start with, I invite Dr. Ritambra Mehta, the chairperson of the Women and Child Mental Health Subcommittee, Indian Psychiatric Society Western Zonal Branch, to come forth for the welcome address.
Thank you, Nilima ma'am. As I was given this opportunity when I was in the last conference of S-Zone, and Dr. Bhave said, would you be able to do this? And I very enthusiastically said yes. And I'm sure that the whole new year will be much, much eventful. And we as women, I mean, I see all, though they have clubbed this women and child mental health subcommittee, but sir, we all are women here except maybe our advisor and your central team, sir. So I really welcome you, sir, and thank you
Thank you
for
so much.
joining us for this first webinar, and we need your blessings. And your whole team is, I think, for many years these activities are going on, and your team also, I think, is very supportive. So thank you very much, sir.
Most welcome.
And we also have from your side, Dr. Abhijit is there. And welcome, Dr. Abhijit also. And
Thank you, ma'am.
he's a, yes, sir. At this occasion, shall I introduce our subcommittee, or shall I ask Dr. Bhave? Sir, would you like to say something?
Yeah, I think I'll say it right now because then I
Yes.
might have to log out because there's a
Yes.
crowd of relatives around me as you might be
Yes, yes.
seeing. Yeah.
Yes,
So thanks
yes,
a lot,
yes.
Ratambara ji, for introducing me. It's a great pleasure for me that we are having the first online meeting of Women and Child Mental Health Subcommittee. I must say that, ma'am, your subcommittee is amongst those few subcommittees that have become active from the very start. I can
Okay.
see the fairly large number of communications on the WhatsApp group, and so many posts being posted, and a lot of brainstorming happening. And I think that augurs very well for the subcommittee for the next 1 year. I'm very sure that
Thank you, sir.
with the kind of academic thought that has gone in, it was really wonderful. Having the first talk on perhaps the most complex topic in child mental health, autism, I think that's a good thing. I'm sure Dr. Shanoy, with all her expertise, all her eminence, is going to lay bare some of the things we find difficult in practice. Because as we know, autism is a extremely complex problem, multi-layered, cannot be handled by one specialty alone. It needs a multi-pronged approach. And I'm sure that the deliberations for the next 1 hour, they, there would be several take-home points by the end of it. I'm very certain about that. So, it's a great thing that you have chosen this as the first topic and Dr. Shenoy as the first speaker. So, I wish you all a very happy and enriching next 1 year. And I'm very sure that the way the committee has been going for the past few weeks, I'm sure that the committee is going to do a lot of good work in the coming year. Now, this year we have clubbed the two committees, women mental health and child mental health.
Yes.
And I'm sure, that's a lot. You also have to deal with CAP, child and adolescent psychiatry, as well as women's mental health. These two are linked in some way, though not entirely so. So, there is a lot of scope for including programs which pertain to children, adolescents, women. And I'm sure, under your baton, Dr. Ritambara, the committee will do well. So,
Thank you very much.
thanks for inviting me today here, and I wish you all a good luck. Thank you.
Thank you very much. I would also invite Dr. Abhijit if he wants to say a few words initially.
I am very eager to listen to Anjali ma'am. Only one thing I want to say is, ma'am, please, the committee, as a committee, please keep a record of all the activities we are doing. That is the only thing.
Sure,
And,
sir. And
That's it. Thank
I'm
you.
sure this Zoom meetings also must be recorded, right, sir? And we'll get the
Yes, yes,
link.
ma'am. It's recorded, and this recording will also be put on the website.
Sure. Definitely, sir. Thank you, sir. So, starting with uh, our committee members who are actually part of the West Zone IPS itself. We have our advisor, Dr. Bhushan Shukla. He is actually not present today, but we are very thankful that he is our advisor because he is a stalwart child and adolescent psychiatrist from Pune, and he's running this Trimiti clinic for last maybe more than 15 years or so. And then we have the EC coordinator, Dr. Khyati Mehta. She's here, madam. And she also has been, I know her from her residency days. She has actually done her MD from BJ Medical College. And she, again, is a very, very versatile and dynamic lady. She also is running her Sakhi clinic and very interested in women's mental health as well as child and adolescent psychiatry. So, and Dr. Akshada Amonkar, who is our convener, she is again a psychiatrist and the therapist from Goa. We have only one member from Goa, so there's a lot on her. Maybe we could have chosen one more member, or still we can add if Dr. Bhave permits later on. We can ask Akshada if there is one more member from Goa. Then in the subcommittee, we have Dr. Nilima Shah. She's our assistant associate professor at NHL Municipal Medical College at Ahmedabad. She also, I had the opportunity to work with her as she was assistant professor here in GMC Surat, where I worked for more than 24 years. She's an excellent teacher, and she did her FAMER also, and she's a very active member of AHPE, and as an MU a member, she is really doing wonderful. Then we have Dr. Swati Shelke. She is a assistant professor and at Nair Hospital and LTMC Mumbai. And she has very vast experience of a child and adolescent psychiatry, as she's also in charge of the early intervention center and rehab center which she's involved in. And I'm sure, Dr. Swati, you are going to be a great asset for the subcommittee. We have Dr. Neha Salankar Bhave, Dr. Bhave's daughter, and welcome, Neha. And you are based at Nagpur. You are a consultant psychiatrist, but as we go through your last conference, also you had taken a session which was really wonderful, and having gold medalist career all throughout, also being trained in adolescent, child and adolescent psychiatry as well as CBT. No, management training you had. So wonderful to have you also. And we have very young psychiatrists, Dr. Alapi Prajapati. She is assistant professor at GCS Medical College, Ahmedabad, and she has done her postdoctoral fellowship at Jipmer in Child and Adolescent Psychiatry. Wonderful to have you, Alapi. And Dr. Ila Vatsala Sharma, she is again a consultant psychiatrist, a very dynamic lady from Vadodara. So, welcome you all as subcommittee, as a team. I'm sure we are going to do wonderfully well. Welcome all. Over to Nilima, ma'am. Dr. Nilima.
Thank you, ma'am. Now, once again, I invite you to introduce our chairperson for the webinar today, that is Decoding the Complex Puzzle of Autism Spectrum Disorder. I would like you to introduce our chairperson, Dr. Hinal Shah.
Right. So let's begin our first webinar. And again, as Dr. Bhave said, a very challenging and complex subject of autism. 1 hour definitely is not enough. But this is going to be the beginning, and maybe for us that Dr. Heenal Shah is sharing. She is actually a professor and head of Nair Hospital, and again she has very vast experience of child adolescent psychiatry, as well as she is also a FAMO fellow and many laurels in medical education also. Dr. Hinal, thank you very much. At a very short notice, you actually accepted our invitation. You have actually been having a very elaborate CV, and your achievements, as you have written, you have actually achieved St. Vincent Thomas Tower Fund for Development of a Skill-Based Fellowship Training Program in Child and Adolescent Psychiatry, as well as you also are in having International Fellowship of Medical Education, IFME also, other than Famer at Philadelphia, and by Savitri Bai Phule Award for excellent work in contribution in the health services in the Municipal Corporation of Mumbai. Thank you very much, madam, for joining us. Thank you.
And now I invite Dr. Khyati Mehtalia, who is our EC coordinator, to introduce the speaker for today, Dr. Manjari Deshpande.
Dr. Khyati, you can come on the screen. You can start your video.
Am I audible and visible?
Yes.
Yeah. Yeah. So Manjari is a dear friend. Dr. Manjari Deshpande Shenoy is an accomplished and dedicated expert in the field of child and adolescent psychiatry with over a decade of experience for transforming young lives. She is a specialist practicing exclusively in child psychiatry. She holds a DNB in psychiatry and a fellowship in child and adolescent psychiatry. Dr. Manjari leads the Indla's Child Guidance Clinics, a pioneering chain of multidisciplinary centers across Mumbai, Vijayawada, Vizag, and Hyderabad, providing holistic mental health care for children and adolescents. She spearheads a team of therapists committing to catering to the diverse needs of young minds and their families. She is an advocate for mental health awareness, conducts several workshops for schools and doctors. She is very well trained in evidence based therapeutic modalities such as dialectical behavior therapy, cognitive behavior therapy, and REBT. Through her vision, expertise, and leadership, Dr. Manjari Deshpande Shenoy continues to inspire change and hope in the realm of child and adolescent mental health. Over to you, Dr. Nilima.
Yes, so now I invite Dr. Heenal to briefly introduce the topic, after which Dr. Manjari can take over.
So congratulations for the first beginnings of this subcommittee. And it's a pleasure for me to be here on this day and see all these interested, excited people. We've reached 45 and this is 8 o'clock in the evening. So, and December, Christmas time, holiday time. So great going. And it's wonderful to be here, not only with the team, but with Manjari. We just shared the stage just 2 days ago in Nagpur, where she was presenting cases which I was moderating. So it's wonderful to be here. And really, decoding autism is a apt name because you need knowledge to understand complexity of the condition, because autism is not a single experience. but a diverse range of traits and challenges that can vary so much from person to person. So, advances in research, early diagnosis, therapeutic interventions continue to improve outcomes. And they will provide a better support for those who have autism spectrum. And while there is a neurodiversity movement that encourages us to be more inclusive and accepting to approach autism in society, we at the same time have to keep looking for ways of making lives better. So I'm looking forward to hearing Manjari's discussion and enlightening all of us on how really to approach and help those that require help in their distress. Over to you, Manjari.
Thank you, ma'am. Always nice to be chaired by you. Yes, we shared the dice 2 days ago, and very nice to be part together for this first webinar of this wonderful committee. So yeah, without taking much time, I will start with my topic. So I was asked to speak on autism and yeah, to make it a little easier basically for everybody to understand. Like Hinal ma'am said, every case with autism is different. And yes, I won't go into the nuances of DSM and the theoretical part of autism, because I think when we're in clinical practice, what to do with every case, how to diagnose a case of autism if we have or if we don't have a multidisciplinary team. So over the last 10 years that we have been seeing kids with autism, we have found some ways in which it makes it easier for us to diagnose and to help these children. So I'll be speaking about what we exactly do and how we can make it easier for each one of us to understand a little bit about this complex puzzle of autism. So yes, this is my favorite quote about autism. We have about 100 plus kids of autism at our center. And yes, each one is very different. So there is no one formula for any case with autism. If you've met one person with autism, you've met one person with autism. So that goes to say every case is unique. So the diagnosis, the treatment plan, everything is very individual to every case that we see. Yeah. So what I'll be dividing my presentation. So I'll talk a little about prevalence, why it's increasing now, what are the diagnostic criteria, just in brief, a little more focus on how do we diagnose in OPD, even in a heavy OPD, even in people who don't specifically see child psychiatry. I'm sure that we come across children with being brought with symptoms of autism. So what to ask for, what to see in these kind of cases. Investigations only if necessary, what kind of investigations do we need, and overall, what is the treatment plan, whether you have a team or whether you don't have a team. So just beginning with some cases, and I'm not sure who's doing that. Okay, so just trying to talk about some cases that we commonly see at our clinic. So a 3-year-old boy, A, brought by his parents as nursery teachers and asked them to seek an evaluation. This is generally what happens. The nursery teachers or somebody from home refers them to us. The boy was saying single words, but out of context, not able to speak in phrases, unable to sit in one place, not showing interest in other kids, playing by himself, saying a lot of words, but the words don't make sense. They're mostly incomprehensible, kept flapping his hand and making some weird sounds. So when we get such a case, our first thing is how do we evaluate, how do we diagnose, and how do we plan the management of the case. Sometimes we get cases like this, where Miss S, a 5-year-old, has been brought to the clinic by parents, both doctors. The child has already been diagnosed as autism by their pediatrician. Both are extremely well-read, being doctors very well-informed and know about all the latest developments. They have come to our clinic because despite all their efforts, they're doing therapy in another city, and despite all their efforts at occupational therapy, speech therapy, their daughter is having terrible meltdowns and aggressive behavior. She is due to join kindergarten from the coming year, but no school is willing to take her. So often, many a times, we do see cases like this where they're already diagnosed, they're already started on therapy. So what do we do? So in these kind of cases, when do we think of medications and which medications can we look at? Another case, something that we see very, very commonly, a 4-year-old child brought by their pediatrician. Child was not referred by their pediatrician. Child was not saying any meaningful word, not making eye contact, not responding to name call. After thorough evaluation, it was conveyed to the parents that the child shows symptoms of autism spectrum disorder and they should start therapies at the earliest. This is what we conveyed. We do have therapies, so we convinced them that they must start therapies at the earliest. The child is already 4 years and there are very clear signs of autism. the parents start arguing with each other and blaming each other. This happens quite commonly where they kind of blame each other for their parenting styles, or they start arguing. The grandmother who was present there kept repeating that the child's father was also speaking very late, started speaking after 5 years of age. So she kept saying that all this evaluation was not needed and they don't need to be here in the first place. So here, more focus, more than the diagnosis or anything, here we must begin with psychoeducation of the caregiver. So how do you educate a family? How do you convince them? How do you make them realize that this is not just speech delay or anything, but it is symptoms of autism, and why the child needs to be started on therapies or on some treatment protocol at the earliest? So prevalence, something that was very, very rare. I think the old estimate for autism in 1985 is 1 in 2,500, but we'll all agree that of late, we've been seeing a surge of cases in autism. In 2021, the statistics said 1 in 44 children. To the latest statistics from CDC shows that 1 in 36 children is now diagnosed with autism. I remember when we started our centers in about 10 years ago, I used to see about 1 case of autism in a week. Today, I think every single day we diagnose at least 1 child with autism, and with or without therapy. And that's how alarming the increasing prevalence of autism has become now. So again, what is the cause? And we know that autism, we don't have a specific reason, no specific pinpointing etiology. 10% of autism cases might have some kind of genetic or neurological condition. There has been a 75% increase in the prevalence in the past decade, which goes on to say it's extremely very, very high. 4 boys to every 1 girl is diagnosed with autism. It is still more common in boys. And that's also what we see at our clinic, that there are far number of boys, but it does not mean that girls can't get affected. Girls do get affected, but the number of boys presenting is definitely higher. So what is the reason for this increase in numbers? As we all agree that there is an increase in numbers, could it be because of increased public awareness? Yes, some reasons. The parents bring their child right at 12 months, 14 months. Pediatricians now know a lot more. So the pediatricians do refer when they see early signs. The diagnostic criteria, we know from DSM-4 to DSM-5, there has been a big change in the diagnostic criteria. So it's broadened, and it comes under autism spectrum disorder. And yes, there is a much better understanding of autism in clinician. This could be some reasons why there is such an increase in the numbers of autism. Won't go much into etiology because this is something anyway we don't know, but there is an increase in the number of copy number variations. There are a lot of gene variations. There are genes that are responsible for synaptic plasticity, synaptic scaffolding, etc., which may be postulated. We know that the corticostriatothalamic circuits and the ventrotegmental area, etc., are areas of active interest, which is why their understanding of others is less. Functional neuropathology studies show excessive synapses because the pruning that generally happens is slower in these children. So coming to the main part, what do we do in our clinics every day? How do we help such a child or such a family that presents with this? What exactly is autism spectrum disorder? It's a neurodevelopmental disorder characterized in varying degrees by difficulties in social interaction, verbal and non-verbal communication, and repetitive behaviors. So this is just the broader DSM criteria. The first group in DSM-5 says there have to be persistent deficits in social communication and social interaction. There are 2 out of 3 have to be present to be able to diagnose autism. So the first is deficits in socio-emotional reciprocity, deficits in non-verbal communicative behavior. So not only the child can't speak, but even the non-verbal communication is disturbed or lagging. Deficits in developing and maintaining relationships appropriate to the developmental level. The second group is restricted repetitive interests and activities, in which there are stereotype repetitive movements, motor movements, excessive adherence to routines. They get very disturbed when their routine changes, excessive resistance to any kind of change, highly restricted or fixated interests. So their interests in toys, interest in clothes, etc. is very restricted and fixated. Hyper and hyporeactivity to sensory input or unusual interest in sensory aspects of the environment. I'll talk about all of this in a little while. So before we go into all this, I think some of the clinical pearls, some of the things that I think have helped me in the last couple of years, understanding of autism, seeing more and more kids with autism. So just giving a brief of what some of the main milestones or some of the things that we need to look for in a child with autism. So we know of this concept of social referencing. When you look at kids, when you look at infants, babies, sometimes they do something and then they look at the adult around them they look at the adult to say, look at me, I'm doing something great. Or then they're unsure of what they're doing, they check around their parents, etc., to see if what they're doing is okay or safe. This concept is called as social referencing. This in in children, it begins around 8 to 10 months of age. Then most kids start responding to their name call. So they start understanding their name, and whenever their name is called out, they start responding, or they start looking to see where their name was called out for, generally by 1 year, that is 12 months of age. Pointing, another important social milestone. So generally you ask the child, where is your mama, where is your father, where is the fan, etc. And the child points, or he at least looks in the direction of what is being asked, the common objects, common people at home. By around 18 months, the child has some fair idea of the people at home and some common objects and can point. Children by 1 or 2 years, between 12 to 24 months, they start following one-step commands. So come here, give me, take this. These are simple one-step commands that the child between 1 or 2 years starts following. Why this is important is because some of these are missing, and that is the first few signs of autism that we can watch out for. Another important social milestone is joint attention. So many times when you give a child a toy, the child is busy playing, and then you suddenly call out the child's name and ask him to look somewhere else. The child should be able to divert their attention onto something that you want. So when two people share interest in an object or an event, and there is understanding between them that they are both interested in the same object or event, this particular milestone emerges around 9 months, but is well established by 18 months. This is something that we can all check for routinely in our OPDs when we have kids presenting with some kind of delay. So if you give a toy to the child and then you ask him to just look somewhere, look here, there is a fan, look here, there is a butterfly. And you can see whether the child, diverts his attention onto something that you are trying to show. Stimming behavior. This is a pattern. This belongs to the ritualistic or repetitive restrictive behavior that we see in children. Basically, self-stimulatory behavior, often also called as stereotypic behavior, refers to specific behaviors that include hand flapping, rocking, spinning, or repetition of words or phrases. So any action that is being repeated or any word that is being repeated, this is termed as stimming behavior. So when we come to diagnosing ASD, autism spectrum disorder, how do we do it generally at our clinic? So we do an observation, we take a detailed history, we check why they are here. So whether the caregiver is brought here, come them here by themselves, whether the parents have come, whether the teacher many a times in preschool has referred, the parent may not know, but the teacher tells them to get a consultation done, or whether their regular pediatrician has asked them. So check with them as to why they are here, what concerns them. We sometimes do some clinical assessments by our clinical psychologist. And then because we run a multidisciplinary team, we get an evaluation by an occupational therapist, a special educator, and the speech therapist. And then we reach the final diagnosis. Once we reach the final diagnosis and we know we're looking at autism spectrum disorder, the most important step before starting treatment is psychoeducation of the parents, where we take them into confidence, where we explain to them about the condition so that they understand what they are dealing with, and handhold them throughout this journey. A multimodal approach definitely works the best if you have a team and you have some specialty discipline therapists who can work with the child. So I think the two core elements of the diagnostic process are, first, a detailed developmental history. So we ask the parents some question, cover their first concerns, ask the early developmental history, right from the time the child was born to when the child started walking, when the child started saying their first word, when did he start understanding his name, when did he start pointing, etc. Then you also observe the child, just spend about 15-20 minutes with the child, even if you have a very busy video, 15 to 20 minutes time spent with the child, where you give him a toy or give him a choice between 2-3 toys and just watch him play. Structured and unstructured assessments will help us to understand. So when can autism be diagnosed? We are all very sure that we've been hearing a lot about early intervention. So how early can the intervention start? Research has shown that autism can be diagnosed as early or even before 1 year of age. And the earliest signs of autism involve the absence of normal behaviors. Many times as doctors, we try to find out what's missing. What is abnormal? Is there repetitive behavior? Is there stimming? But I think in autism, the first thing is to check if the normal milestones, what I mentioned earlier, the pointing, the joint attention, the response to name call, are they there or not there? Because before the stimming and before the repetitive behavior starts, most of the time what we observe is those normal milestones have not been developed. So the earliest signs of autism involve the absence of normal behaviors, not the presence of abnormal ones. So there is a lot of research that is done on eye contact. I think Dr. Heenal ma'am can then share with us. I think Nair Hospital is doing a lot of work on this, where there is babies have been their eye contact has been tracked to see whether how how their eye contact keeps on developing. So the siblings who don't develop ASD show the opposite pattern. That means eye contact increases month by month. However, in the kids who develop autism, there is a steady decrease in the amount of time that they looked at a caregiver's eyes in the video. So these are some milestones that we all must be aware of. And, these are some of them which I mentioned earlier, like a baby of 3 to 6 months smiles. He gives this typical social smile. You look at an infant of even 4 months, 5 months, and you smile, generally the child smiles back. A 12-month-old child can imitate. So you just make some funny action, or you say a funny word, the child will try to imitate back. Also expresses anxiety when separated from the parent. So around 9 to 12 months, they have typically developing stranger anxiety. So when taken away from their parent, they develop some form of anxiety and start crying. Many a times when we're looking at a child who may develop autism spectrum, this anxiety may not be established or may not show the anxiety. Around 2 to 3 years, they start saying no to adults. They enjoy playing with other children. So peer play comes in by around 2 years of age, when they want to be with other children. They want to share their toys with other children. They want to play. So these are normal milestones that develop. And in kids with autism, these develop slower or don't develop according to those age. So knowing these basic milestones will help us to understand how this child is responding. These are red flags. As we know, we use this term very, very commonly, and these are red flags that we all must be aware of. So absence of big smile, absence of warm, joyful expression by 6 months, no back and forth sharing of sounds, no back and forth sharing of smiles, other facial expressions by 9 months, absolutely no babbling. So babbling is when they just make sounds, baba, kaka, dada. So if that is absent by 12 months, no pointing, what I mentioned before, or reaching out or waving, you just wave and the child doesn't wave back by around 1 year. No single words generally begin by 1 year. So we generally remember it as single word by 1 year, 2-word phrases come here or give me by 2 years, and three words put together making a sentence by 3 years of age. So absence of any single meaningful word by 16 months, no meaningful 2-word phrases by 2 years, or most important, any loss of speech, babbling, or social skills, basically termed as regression. So many a times parents come to us and say, the child was speaking, the child was saying mama, the child was giving eye contact, the child was waving out, etc., and then suddenly stop doing that. That's termed as regression. That generally begins between 18 to 24 months of age. So these are red flags, and when we see any of these, that's when we have to do a more thorough, detailed evaluation of the child. So these are summing up the symptoms of autism: not making eye contact, not showing interest in other children, not consistently responding to their own name being called out, repeating body movements like flapping hands, walking of toes. This we can even observe in the OPD. Not engaging in imaginative play. So around 2 years of age, the imaginative play comes. You give a cup to the child pretends to be drinking, or you give a comb, the child starts pretending to comb their hair. So not engaging in this kind of imaginative play. Focusing narrowly on objects. So you give him toy, you give him a car, he'll only focus on the wheels of the car or line up the toys. Copying direct phrases. So many a times parents tell us this, oh, but my child is speaking. So you say, okay, what does your child say? So you'll say, he can repeat everything from the cartoon. But then when you try to just ask the child, how are you? The child is not able to answer that kind of question. So parents often mistake it, saying that the child has speech development. So that's just a copying of direct phrase because of what they're hearing from TV. Seeking certain sensory experience like rubbing toys on the face, etc. Getting easily upset by change and has to have a particular rigid routine. Sensitive to sensory experiences like loud noise, bright lights, or certain textures. They can't wear clothes of particular texture. They don't like their hair being cut, etc. Intense interest in certain toys or objects that may be inappropriate for their age. So these are some of the common signs that we see in children who may show signs of autism spectrum disorder. So why early intervention? Why should we diagnose early? Because early diagnosis hails early intervention and thereby a better lifetime prognosis for the child. This is something that research has proven, and we have also seen in our clinics that when the diagnosis is achieved before the age of 2 years and we've started therapy, the results are much, much better. And we do see a lot of change in these kids if the therapy was started early. We all know that this is because of, the plasticity of the brain and maximum brain development happening in those years. So exposing the child during the critical brain development period to therapies definitely gives us better results. So again, a case, a 3-year-old boy was brought by parents with complaints of no two-word phrases, not able to name common objects, not even nodding. The child can't speak. You just try and ask him yes or no questions. The child cannot nod. Playing by himself, flapping hands, jumping, lining up of toys, watching the wheels of the car, stacking objects, self-absorbed, no interest in what's happening around him, getting uncomfortable with anybody. Mother reports that at 1 year, he was saying 2-3 meaningful words, but the last few ones, the child has stopped saying them. So there is regression to a certain extent. Playgroup teachers complain to parents that he's not interacting with anybody. He would be lost in himself. We did his testing. ESA is the Indian Adaptation Scale for Autism. The score was 92. Above 70 is diagnostically mild autism. We did an IQ test, which is Sengphon board test, which was found to be good. The IQ was 131. We started occupational therapy for him and speech therapy. And now about 1.5 years into therapy, the child is now speaking in phrases. He gives consistent response to name call. His eye contact is not the best, but definitely improving. Has actually started enjoying playing with other kids. The flapping has come down. He can sit and complete his activities and is even able to follow complex or 1 or 2 step instructions. So this is the result of therapy. But what do you do if you don't have a multidisciplinary team? How can we, if we don't have the OT evaluation, you don't have the speech evaluation, what can single standalone practitioners do? So how do you take history? I know most people who see adult psychiatry see a lot of patients in a day. So obviously you cannot allot like 45 minutes as we do, but how do you take a brief history in a short time? What questions will you ask parents, or what will you look for when you are trying to observe the child? So some of the useful questions that I felt over the last few years, I've tried to sum it up. So these kind of questions help the parent to get an understanding. So does he look when you call out his name? Asking the parent these questions, does your child look at you when you call out his or her name? Does he point to common objects? So when you say the fan, does he point to the fan? Or when you ask him where is daddy, does he look at daddy? Does he follow instructions? When you say look here or bring this, does he follow those instructions? When your child is absorbed in something and you're trying to show him something else, does he divert his attention and look in the direction that you're trying to show? Ask for milestone development, right? From motor milestone to speech milestone development to social milestones. Ask for the development of milestones. Ask the parents. Many commonly they cannot report regression, so ask in a way that you ask them, is there something that your child picked up, was saying something, was doing something, and now does not do anymore? You can elicit regression through this question. Does he call out to you as mama or daddy? So many times the parents say he says a lot of words. So what words? They're words picked up from TV, but does he call out to you as mama, daddy? No, many a times he does not. Is he able to communicate his needs either verbally or not verbally? Does he nod yes or no? When you ask him something, can he say a simple yes or a no? You ask him, are you hungry? Do you want to go to the toilet? Even if the child is non-verbal, the child should be able to nod yes or no. Does he do something or say some word repetitively? Does he eat solid food? Because many of the time these children have sensory issues, due to which even at 4 years, 5 years, the parents are giving them mashed food or food through the mixer. That's because the child is not able to process the solid food. It may be because of sensory issue. Asking what kind of toys does he play with? Can he do pretend play? Does he like the company of others or prefers being by himself all the time? So these kind of questions are helpful for understanding or asking parents kind of routine questions in the OPD. What do we look for? So you give a couple of toys to the child, or you have toys with you, and you just try to initiate some of these. So try to see if there is reciprocal social interaction. So, you typically take a toy, hide it, and then try to say peekaboo. Does the child look out for the toy? You try to show him something in your room and you say, oh, can you look here? There is a toy. Most children with autism will not follow. They'll, be self-absorbed, and they'll be doing something of their own. Does the child use his index finger to point out or indicate interest in something? If you have an interesting toy, does he ask for it? Does he try to come near the toy? you try to see how is the communication of the child. Is there verbal communication? If not, what is the non-verbal communication? Is he giving you eye contact? You try to sing a rhyme, you try to talk to the child, you try to see if the child keeps looking at you or is least interested in the communication. What kind of facial expressions the child does? Is he making any gestures? You try to make some funny faces, funny sounds to try to see if imitation is present, imagination is present. Give a couple of toys to see what kind of toys he seems to be interested in. Are there any preoccupations? Are there unusual sensory interests? So they might just keep looking at the fan or keep, making some noise that might seem very interesting to them. So summary, I think what can we do? Let the child play in your room for 10-15 minutes. Observe what toys he picks up. Observe how he plays. Observe the reaction when separated from the parents. Like I mentioned, separation anxiety is supposed to be there by 18 to 24 months.
ನಂದಾಯ್ತು ಪದ್ಮ, ನೀವು ತಗೊಳ್ಳಿ.
Check for imitation, joint attention
Sir
response.
Manjri, can I request others to please put their mics off?
Yes. Check for imitation, joint attention, response to name call. You can elicit these from the child, from the parents. Observe for toe walking. Observe eye contact. Check how he is responding to commands. You ask him to come here, go there. Observe for sensory symptoms or repetitive behavior. Try to strike a conversation. If they're older, yes, you can strike a conversation and see whether they are able to engage in a two-way communication with you. Check for echolalia. So what is your name? Instead of repeating, saying their name, they may just repeat the question asked or pronoun reversal. Investigations when necessary only. Most of the time we don't need it, but if needed, a hearing and a visual evaluation to check if the child is very young and we're not very sure. So hearing and visual evaluation only when needed. Speech, language, psychological evaluation if we have the multidisciplinary therapist. CBC, TFT, lead levels, amino acids, Fragile X testing, chromosome testing, EEG, brain MRI. Again, only if necessary. I don't think in routine practice we need these every day unless we see some neurological condition or we want to check for any genetic issues in the child. So coming to the psychological assessments, there are some very good standardized assessments that we can do. CARS2, MCHAT. MCHAT is a screening tool that is used for toddlers. Sometimes parents have done the MCHAT at home online themselves and come to us and tell us that, yes, my child is at risk for autism. So what do we do? In our clinic, and I think across, we do ESA, which is a very good there are 6 domains in that scale, and it tells us exactly what domain is affected. It tells us also the severity. So no autism if the score is less than 70. If the score is between 70 to 105, it's mild autism. If it is up to 135, it's moderate. And if it is severe, it's generally above 135. So these are some investigations or some tools that can be done by a clinical psychologist if available to understand not only the presence of autism, but also to see the severity. We generally, after 1 year, we repeat the test to see the progress in the child. Coming to management, yes, what do we do? We're lucky we work with a multidisciplinary team and we see results with that. So what kind of therapies are recommended? What is the gold standard? What if we don't have therapies? What is the medical management? Because there is sometimes these children, like I mentioned in the second case, even a child who's ongoing on therapy sometimes may need the help of medication for managing some of the behavioral issues. So I think, yeah, Temple Grandin is somebody who has done a lot of work in this area and a lot of books written. There need to be a lot more emphasis on what a child can do instead of what they cannot do. And especially this holds true for autism. So coming to goals. So I like in all our conditions, I'm sure we all try to see what are the goals, whether we are starting medication, whether we are starting therapy as doctors, we try to understand what goals do we have to set for this child, for this adult. So I think the goals in autism are first to minimize the core problems, that is the core problems of autism, maximize independence. That's all what parents want. You know, one of the first few questions, I have it a little later, is common questions asked by parents. So how will my child be independent and how will the quality of life get better? Most important, I think, helping the child and most important, the family to cope more effectively with this disorder, because like we know, it's a neurodevelopmental lifelong disorder. So helping the family to accept and also cope with this disorder is an extremely important part of our treatment. So we generally divide the treatment goals into 2 types, where we are stimulating development, that is through the neurodevelopmental therapies like occupational therapy, speech therapy, remedial, etc. And if we want to remove the disruptions in their everyday life, the behavioral issues, the sleep issues, the aggression, the hyperactivity, those can be targeted by therapy, also by medication. So again, we have speech and language goals where the goal is to improve communication, whether it is verbal or if it's a non-verbal child, to improve the non-verbal communication. Behavioral goals to minimize the behavioral issues that are present in autism. Social skills, because we know one of the core features of autism is they're not able to socialize. But yes, therapy helps immensely for helping them to garner some social skills. Educational goals try to see that every child can be put in mainstream school. If not, what are the other options? And life skills in general, helping them to develop some of the life skills that will be vital. One important part is how to break the news to parents. Yes, because I think depending on how we tell these parents and how we are able to convince or communicate to them, the entire, the treatment protocol depends a lot on that. So generally, psychoeducation, explaining to them about the diagnosis, the prognosis, and what would be the line of management is important. So many a times, these are some emotions that we see very commonly when we break the news to the parents. We tell the parents that, yes, your child seems to be having some symptoms of autism spectrum disorder. The reaction that parents show can be varied. It can be denial, where like the grandmother in the third case, complete denial, no, this can't happen. A lot of shame. Sometimes parents feel it was something wrong that they did in their pregnancy or in the first year of life, and that's why they blame themselves. Many a times we see parents fighting or blaming each other or feeling guilty for this. A lot of confusion, because you are telling them it's a neurodevelopment condition, you're telling them it's a lifelong thing which does not have any medication. So obviously it can lead to a lot of confusion, a lot of fear, a lot of helplessness that parents and families feel when we break this news to parents. So some factors that I think are important to consider when we break the diagnosis: explaining the basics of autism, what it means, depending on their educational understanding, etc., the need for intervention, making parents understand that it's a lifelong neurodevelopment condition and it's not going to go away for after few years. So we can't just give them false reassurance, but we tell them that yes, there will be help available at every stage, but it's kind of like a lifelong disorder. Most important, I think a lot of parents blame each other or blame their own or each other's parenting techniques. Vaccines, because I think what I've observed is MMR vaccine is generally given around 18 months of age, and we see a lot of children who show regression around the same age, and it just happens that the vaccine is given at that time. So many parents attribute it to vaccine, and many parents are from the anti-vaccine, like we don't want to give vaccines because that might cause. So explaining that autism is not caused by bad parenting, vaccines, or even the lockdown. Even today, we have parents who come to us for various conditions, and the only reason that they put it is on the lockdown, that my child is a lockdown child, my child is a COVID baby. So any baby born after 2020, I think till 2023, they just call it a lockdown baby, and they attribute all these symptoms to saying it was the lockdown and we were not going out, etc. So explaining that it's not caused by any of these is very important. A lot of studies have shown that parents of children with autism experience a higher level of parenting stress. It affects the marital relationship. We have seen in our clinic couples break up, have divorce, mother moving out from the family, etc. When we break the diagnosis, it can have severe financial crisis. In private, obviously, the therapies are expensive. There is still not enough medical insurance, so there is, and it's quite a long treatment duration. High parental stress levels can lead to poorer adaptive functioning, thus worsening the symptoms. That's why it's necessary to get the parents on board and work with the parents in each step. So again, explaining about autism, its symptoms, the cause, outcome, removing the guilt, blame, and shame, helping them accept the child unconditionally, setting therapy goals. So what we do is we set 3-month therapy goals, and every 3 months we review those goals with the parents, giving them a home program, having them involved. So even if they are not on therapy, but giving them some techniques that they can do at home and making sure that they do. Stressing on the need for regular follow-up, addressing medical comorbidities. Many of the times these children do have sleep disturbances, gut issues, other medical reasons that need to be looked into. Of course, as a general rule, reducing the gadget use and increasing interactive play with the child. This is a list that I summed up of the commonly asked questions. When you tell them that your child has symptoms of autism, there are some very commonly asked questions, and it's important that we are prepared for these questions. So is there a cure? Does it mean my child will never speak? Can he go to normal school? When will he be normal? This is something I think every parent asks, when will my child be normal? Can my child complete his education? Can he get married in the future? Will he be able to make friends ever? How long will these therapies continue? Is it because we showed too much of TV, or is it because I did not take care during pregnancy? So I think for the first couple of questions, we may not have answers when we just see or when we just diagnose the child. So important to tell them, let's, just be short-sighted for now. Let's just see every 3 months. And then, overall, we can try to keep reviewing the goals and understanding how this child will do. So the interventions that are supported by significant scientific evidence, we have some interventions that have proven from a lot of time that these interventions do help. So understanding what helps and not helps is important. Some of the therapies that we have done and we are doing and we see a lot of use is occupational therapy, speech therapy, behavior therapy, group therapy, especially for social skills intervention, remedial therapy or special education. In these, what are the target symptoms? The initial target symptoms for most of these therapies are to promote eye contact, improve response to name call, improve following commands, increase sitting tolerance, attention, improve the gross motor, fine motor skills, enhance play and social skills. IAP and all our guidelines have come up about screen timing. This is not only related to autism, but most parents ask us how much time should we show. So some guidelines that as a rule, we can tell them below 2 years of age, any child should not be exposed to any kind of screen. Maximum 1 hour of supervised screen time per day for children between 2 and 5 years of age, and less than 2 hours for children between 5 to 10 years of age. Important to tell them that the screen time must not replace other activities like physical activities, sleep, etc. Social skills training is very, very helpful because the main core problem in autism is deficit in social interaction. There is very good evidence that interventions to directly train social skills are effective, and increasing pro-social behavior is typically a primary outcome. So ABA therapy, social skills training help a lot. Picture exchange communication system. This is something that is done by speech and language therapists. Augmentative communication. So basically, even if a child is non-verbal, the child can learn to communicate, where the individuals are trained to exchange picture cards for desired items, which the therapist pairs with a verbal label for the item. Sensory integration, again, like I said, some of these children have a lot of sensory issues. So that is why they are in distress and they have a lot of meltdowns because of this. We have seen great results with occupational therapy or sensory integration therapy at our center. Now, there are a lot. These parents, like I mentioned at the beginning, are very helpless. They're just looking for some kind of miraculous cure. We have parents who spend lakhs of rupees or do, anything that is available on the internet, only can understand because they're so helpless. So providing them with scientific evidence that for some of these things, there is no evidence at all. Absence of vaccination, stem cell therapy. We still have a lot of kids who spend a lot of money on stem cell therapy and then come to us. Sensory integration therapy, ABA, PECS, social skills training, these are therapies that have stood the test of time. There is no evidence absolutely for stem cell therapy or abstaining from vaccination. Our IPS, Indian Psychiatric Society, has strongly condemned the use of stem cell therapy in psychiatric disorders, especially with autism. So giving them this kind of evidence helps a lot for parents who are helpless and are looking for a miraculous cure. FDA has also cracked down on false claims. There are a lot of things. The moment you put up autism treatment online, we'll be astonished as to what all parents have done. Chelation therapy, hyperbaric oxygenation therapy, detoxifying clay baths. There are a lot of parents who have gone for gluten-free, casein-free diet, a lot of high-dose vitamin supplements. I had a parent who was on very, very high dose of vitamin B12 and vitamin B6 because some doctors had told them that cures autism. So again, telling them that all of these are not a treatment for autism. Coming to medications, if we don't have the therapy, but the child is distressed or there is a lot of behavioral issues, definitely we can help at least a little bit. So again, the medications that we use are not for the core features, unfortunately, of autism, but they are for the associated behavioral symptoms. And sometimes using medication for these will improve the quality of life, not only for the child, but also for the family. Target symptoms include irritability, where Risperidone, antipsychotics like Risperidone and aripiprazole have been approved, and they do help. Hyperactivity, inattention, and impulsivity, where we do try stimulants at times, but we have to be careful because some of them may have side effects. Clonidine for sleep issues, for hyperactivity. Repetitive and stereotypic behavior, not direct evidence, but sometimes some kind of medication can help. So again, typically the medicines that we use, like for ADHD, methylphenidate, atomoxetine, I think a lot of children do benefit from low dose Risperidone and aripiprazole, especially when they have a lot of irritability and a lot of aggression, which also comes in the way of therapy at times. We are all in an inclusive society, and yes, these children should continue in regular schools, and there is a lot of change that I've seen over the last few years. A lot of mainstream schools do take these children and do try to accommodate to the extent possible, at least in our city. Maharashtra State Board does recognize autism as a separate entity, and these children are given concessions to appear for exam, which helps them a lot. Sometimes these children are a little disturbed in school. So a little work around with the school, you work with the teacher, you work with the counselor, you give them some tips as to how they can settle this child. So a deep pressure massage, you tell the parents to do before the child goes to school. They can't sit for long hours. So a little break between the classes. Sometimes they have a lot of sensory issues. So using some things like headphones or weighted cuffs on their feet, grippers, therabands, sometimes are useful for reducing some of these sensory issues. Vestibular movement exercise, swing, trampoline. Now most schools have these usual visual aids. Sometimes teachers now, schools nowadays especially, are asking for shadow teacher if it is necessary, and that may somebody who accompanies the child and may help the child to settle down. So again, a lot of parents do ask us, what is the prognosis? What will my child, how will my child do in life? I think there are no straight answers, but some things that we know, the good prognostic factors are early diagnosis, early treatment. We have a lot of evidence, both in theory and in practice, where if the child has started therapy before 2 years of age, the prognosis is good. Better language abilities, especially by 5 years, better imitation, better motor skills, higher cognitive abilities, decreased severity of the core symptoms like stereotypies. Most important, parental involvement in intervention. Poor prognostic factors may be lack of functional speech by 5 years of age, low IQ, so intellectual disability associated with autism, severe ASD features, or presence of neurodevelopmental or medical comorbidities, which only increase the morbidity factor. So coming to the end, we're moving towards an integrated diagnostic system. So there has been a lot of change from DSM-4 to DSM-5. The origins of ASD still stem from an interplay of complex genetics. I think in time, perinatal psychiatry will be a branch to watch for, which will help us to understand some of this. Early diagnosis through maybe eye tracking will help us in intervention and watching out for the red flag, starting therapy at the earliest. Mainstay of intervention includes therapies like ABA, social skills training, PECs, and OT. Medication role is limited, but yes, in a couple of cases, it is very, very vital. Psychoeducation of parents and hand-holding parents throughout this journey is very important. Pharmacotherapy, mainly involving antipsychotics, and sometimes melatonin also is useful in these children, stimulants or SSRIs. So coming to the end, autism doesn't come with a manual. It comes with a parent that never gives up. And parents, we do understand that these parents do get burnt out. There is a lot of stress. They have to come, sometimes almost every day to our clinic. So having some programs where we, kind of motivate these parents, etc. These are some things that we have tried at our clinic, and we feel it does help the parents. So that's about our clinic. We have 5 branches, and we are doing a lot of work in autism. And yes, we are seeing a lot of change. I think parental involvement is one of the main factors when it comes to this early diagnosis and parental. Thank you.
Thank you, Manjari. That was really, as Abhijit has mentioned, a very, very comprehensive talk. And there are some questions before we open out further. I think one of the questions that Karima is asking is, how do you deal with denial? That's one. Ipsita has asked for, can you show that slide on medications again and tell us something a little bit about the home program? And also has asked that why is it that you're saying the child is not speaking when they're actually repeating TV ads or TV, whatever it is. So those are Ipsita's questions. And Akriti has asked, what would be good treatment options other than the FDA approved antipsychotics as per your clinical practice experiences.
Yeah, I'll just show the slide for the medication part first.
That's for you, Stan, for the others who missed it.
Yeah. So I think, how do you deal with denial, ma'am? I'll take that question first. So yeah, many a times we see that parents are in denial, and it's a lot of shock, it's a lot of blame. But I think maybe, yes, slowly helping them with resources that help them to understand about autism, being slow, not, giving the entire lifetime prognosis, but telling them we'll take it step by step. Many a times the child is 2 years of age and they throw a question, will my child get married and can he have kids? So explaining to them that, yeah, let's take it step by step. Sometimes helping them to connect with other parents. So we have a support group for autism. I think that helps a lot, where they do see that there are other parents. I'm not alone in this. So they talk to other parents, see how therapy has helped them, see how home programs have helped them. Rather than us telling, I think them connecting to another parent helps a lot. So these are some things that we have done. I think continuously talking to them, even when they come for every session. So even our therapists keep talking to them. You, as a doctor, we keep speaking to them and giving them the reassurance that, along the step, the symptoms may change and the therapy needed may change. There may be some kind of medication needed, but we will help and address each symptom as it comes along the way.
And if I
And
can
most
just add
important,
to
giving
that,
them time to accept the diagnosis. They need not accept at the first
yeah.
thing itself. So giving them time, they do come back, they do their own research, telling them, you come back with your doubts to me, and you bring your doubts to us, bring your family members who are telling you other things, etc. So giving them a little time to accept really helps.
And I think in practical experience, especially when we have very well educated parents and doctors,
Yes.
especially pediatricians who
Yes.
are coming with their own child, denial is very, very strong. So you don't have to break the denial at the first part. So we'll say, okay, you think this is what's causing it. I believe it's this. Let's at least see how we can decrease the distress or decrease that behavior. And then we go along the way and then it happens. So I think we don't have to prove, and we don't have to, and especially in very young kids, we don't have to have a diagnosis first.
Yes.
You just start the treatment, see the improvement. The diagnosis is not the aim. So I think that's one important thing also that helps. And there is another question. Can therapy be helpful in mild autistic child? Can he get back to normal? What's your experience? That's from Dinesh.
Yeah, so even in mild cases, yes, I think even if we have not diagnosed as autism, but we've just seen some signs or some regression or even early signs of autism, starting therapy, if they are in a city and they have the multidisciplinary, I think it helps a lot. In many cases, we have seen a drastic change in a couple of months, 4 to 6 months, and the child is doing quite well. That depends on how young the child is. But even for mild symptoms, starting therapy rather than wait and watch approach is better.
If I again may jump in and add, never give up. Never ever give up. Very often children come to us late, and we know that the most plastic brain is earlier, but you never know what helps. Never ever give up. So never portray a wrong picture. I mean, never portray a picture that nothing can be done. Of course, we could have said that earlier it helps better, but it's never late to try. So don't add to the guilt of the parents that they have come late. So keep trying. You never know what helps at what time. So that is one thing that is also important over there. The another thing that I also thought is that um, in terms of therapies, patients have had so many other things they want to try, like especially stem cell and so many other things. We may tell them don't do it, but that doesn't stop them. Accept it. Okay. I think it's not a battle between us and them that these are the therapies and you have to do that. It's my way or the highway. Both of us have one thing in common, that the child should improve. Maybe they have a different perspective because they're desperate parents. We are coming from science based, but we are not as emotionally invested. So I think sometimes just let the battle be. Okay, you want to try stem cell? I don't think it's required. I think these are the side effects. This is it. But if you want to, that's yet your choice. So or whatever other, I'm not kids who have done stem cell twice, they've done chelation, they've done so many other things. But we have to accept it because we have also not got the best results. So then we can't stop them, though we know that there's no evidence for that.
So generally I tell them, okay, you come back after that and we'll see how you're doing. And then, they come back and, they'll share their experience. We'll tell them, okay, now you start therapies, you've done that. Now we can try and start some therapy for you.
May I add something?
Yeah, sure.
Dr. Hinal Shah, this is Vasanta Giri. I am the 1973 graduate of Nair Psychiatry.
Yes.
I remember
have
meeting
met.
you very well.
Yes.
Dr. Manjari, I want to congratulate you on a very concise presentation that had everything that is important.
Thank you, ma'am.
I'm a child and adolescent psychiatrist. Couple of things. One thing I wanted to add to your recommendations about psychoeducation for the parents. Every parent wants to give birth to a perfect child. When the parent realizes that the child is not perfect, it is one of the first narcissistic injuries to the parents in marriage, other than the partner is not the perfect one. So that is something that takes a lot of time to deal with before they can actually collect all their energies to invest in a lifetime of helping their child. In the US, of course, we have many, many special institutions set up for children on the autism spectrum. Everything from in-home ABA, occupational therapy and speech therapy, it goes all the way to housing young adult aggressive ASD patients. So we have that wide range of services. Of course, we don't have that in India. And what you are doing is amazing. You are putting together pieces to make this continuity in services. One more addition to your repertoire of medications is the use of naltrexone for very aggressive self-injurious behaviors like biting oneself repeatedly, continuously until they break skin and bleed. Naltrexone in very small doses, starting at 25 milligrams and going up very, very, very gradually, is something that helps in addition to all the therapies. I just wanted to add that piece. I don't know if naltrexone is available in India.
No, ma'am, we do use it.
We use it
We've
also.
used
You
it
do,
in children, yes.
okay.
Even lower doses, in fact, have helped.
Oh, I see. Okay, that is excellent. And, the use of stimulants for the hyperactivity, impulsivity, the SSRIs, the SGAs, all that is our package deal. And we pick and choose from it to address whatever is the most distressing symptom at that moment. So if one child psychiatrist sees that child between 3 and 5, the presentation is going to be very different from a psychiatrist who will see that child in latency or adolescence. But again, I am glad I had put this into my calendar and I stayed up for it. Autism is one of those conditions that I have always enjoyed. It has intrigued me and it makes me want to be a better psychiatrist.
Thank you so much for your inputs. And responding to that, Ipsita is asking at what age do you normally give naltrexone? And while, USA has so many things, in our conditions where people are in remote area, Ipsita is asking where all these therapies are not available, how can we support and help parents? So those are two other questions that have come your way.
Yes. I think one is developing a like you said, Dr. Manjari, recruiting and having a whole treatment team. One person cannot do this, simply cannot do this. So you need a whole team of care providers. Even what we call, time out for the parent. providing childcare for so that the mother can leave and go away. And even if it is just to sit and have coffee somewhere, so that she doesn't have to deal with a child who's tantruming or who's, in some way acting out. In India, I know that is not available, but what I would say is if we can set up a system of care providers and start training them to be these very specialized care providers, not today, not this week, not this month, not this year, maybe in 10 years, we will have something much, much more elaborate than what you are so bravely attempting to do now. It's admirable. It's really admirable.
And so I'm just getting it back to Manjari to ask you, Manjari, in your setup, and I know we have a similar setup. In fact, maybe we have even poorer resources. How do you manage if there are people who are from a poor socioeconomic class, people coming from interiors of Maharashtra have come to us with a child? What do we do next? And what are the kind of home programs that you're using?
So for some of these children, ma'am, like routine, I mean, if they're in Bombay and they can afford, of course, we're telling them thrice a week, 4 times a week therapy. But for those who can't afford, we're telling them at least come once in a month where we work more with the parent rather than the child, where we sit with the parent, discuss the issues, if we have an OT or a speech, and they give them some specific tasks and techniques to do for that month. They come back next month to see. So even working once in a while, if you can't work with the child, working with the parents, where we give them some specific activities to reduce hyperactivity, or what can they do, simple toys that they can, or even homemade things that they can use for their motor skills, like, dough, or playing in shaving foam to reduce their sensory issues, etc. So giving them some basics of therapy and helping them once in a while with a home program, I think even that goes a long way. I mean, it's better to do something rather than do nothing at all.
And if I can just add to that, I think we've published a paper where we have the WHO CST program, which is actually for lay people, and you can train lay people to do some of these things. And it's on the WHO website. What are the things you can do for these children? And they've not only limited it to ASD, but for people who are not communicating, and the kind of things you can do. So I think that is one thing. And I think secondly is that there are people now who are doing work online also. Of course, it costs, but somebody staying in the interiors and can't come. Coming so often is more difficult, and there are people who are doing online work. It may not replace what can be done when you're together, but it's better than not doing anything. So those are the things that are also very important. And the third thing I also feel is that there are besides all the supports that we have, there are things like Forum for
FFA,
Autism, FFA, which are very good organizations, and they have large scale things going on, and they're connected across cities in India. So if somebody gets onto them and connects them, they'll connect to people. And then it's their own personal experiences that are important, which help in empowering the people. And Dinesh is asking, what is the minimum cost of therapy? Well, if you come to Nair, it costs 10 rupees for 1 month, but it just depends on which part of the world you are. So we won't get into that, Dinesh.
Yeah.
And
one more thing I want to add, Dr. Shah, is, talking about training the parents. I believe that in situations like this, training the trainer, the mother is the best trainer. Training the trainer and everybody that supports her, so that everybody is on the same page and they are not going to undermine and sabotage somebody else's work. Like the mother-in-law sabotaging the daughter-in-law sabotaging the mother-in-law, or however it works, so that everybody is on the same page. I think that is also important, especially when they are remote and they don't have access to professionals.
Very true. And Dr. Ritambara is asking, do share do share resource stories, and can we share success stories? So one of the things, before I hand it over to Manjari to really answer that question, is that, we do see, we have given a child a benchmark disability, and after a few years, we are removing the benchmark disability. And it's a bittersweet experience for the parent, because it implies the child is now improved and according to the legal thing is not disabled, so won't get all that kind of a help, but it is a sweet moment that the child is better. So there is always improvement. And recently, for Children's Day in our center, we had a child who was once upon a child with autism, who does a lot of painting, come and do it for all the other kids. It's internationally known. We have people who have now with autism who've become, models. So there is so much happening over there. But I don't want to romanticize and talk about all these small people who are doing so much. Most of them will not be able to do all of this. So without having to romanticize and say that he'll become a painter or he'll do that, I think looking at the strengths of each and every child and getting the best out of that and supporting the family would be the best. Manjari, over to you.
Ma'am, success stories, I think over the last few years, I think parents are, I think parents of children with special needs, they celebrate a lot more than we do. As in, we have parents who share very small things with us, which sometimes we would, not even count as significant. And I think that has made me more conscious, probably as a parent, that to celebrate, not only the bigger joys of life. So we have a parent who, in their sports day, getting enrolled in a mainstream schooling, having him to be present on stage, even though he didn't perform the dance. That was the biggest joy of her life. Another parent just shared where he came last in the race, but she was so happy because he is 2 years into therapy. He would never complete anything. He just completed the race. The entire class waited for him, though he was last, but the mother celebrated it so much because that. So I think I think parents have taught us to look at the smaller joys, to look at the small wins every day. And that's what I think makes our job more rewarding. We do have our old parents sharing their report cards or their, the day they went for a party and he could bear the noise, or he went for a Christmas carnival and actually enjoyed himself. I think those are the real success stories that must be celebrated.
Yep.
Yes, yes. Thank you for sharing these. But I would go one point beyond as experts. Like, what helps, if that can be actually put forth, and then we can share with the parents who are probably in the denial mode or they are not coming forth for some interventions and all, that can actually go a long way.
So when we do some parent workshops or when we do like parent support groups, we ask some parent who has done therapy for some amount of time, has achieved something, has, shown some progress. We ask that parent to come and share their story, the videos of what the child was doing, or share their own life experience. And I think that helps parents rather than we telling. I think a parent who has gone through it all, them hearing about it the first hand, I think that really helps them.
Definitely. And maybe compiling, as you all are working in that field, and making a compilation and then sharing on website or some other, of course, with the permission and all, ethical considerations and all. But that can go a long way in actually taking the initial parent, that is the first time diagnosed, parents, they may get more motivated to do more. But it was an excellent presentation and discourse, Dr. Manjari and Dr. Hina. Yeah, please carry on. There might be some more questions.
Do we have time for more?
Moderator Nilima, do we have time?
We can have 5 more minutes, ma'am. I
Oh,
All right.
yeah, sure.
Okay.
Why not?
So I think the other questions that are, do share resources for caregivers as well as for psychiatrists. So one of the things that easily that I can share is Forum for Autism. Just go to their website. They have a lot of things. Umeed on their website has a lot of things available. So these are easy websites to get information, from. The other question that Akriti has is, how do we plan to integrate more of neurodivergence-based therapy over ABA in future?
How? I didn't get the question.
How do we plan to integrate more of neurodivergence-based therapy over ABA in future? I think what she's trying to say is that, we talk more about neurodiversity, and everybody's now, well, parents especially. I don't want to call it so much of autism as much as they want to call it as neurodivergence. And so then when we're talking of neurodivergence-based therapies over ABA in future, is that something that we are going to look at, is what she's asking?
Yeah, so I think a lot of therapists today also believe in neuroaffirmative therapy. So, you don't have to change everything of autism. So if there is a particular stimming, not necessary, you have to overcome that stimming. You can make it a socially acceptable form of stimming. Or if the child is not maintaining eye contact, we don't force the child to maintain eye contact or give us eye contact. There's a whole research on neuroaffirmative practices, I think, and as a society, as we accept them and, help other kids to accept this, I think that will also go a long way in the future.
And I think this whole thing of looking at strengths and affirming the strengths and looking at the strength-based approach is what neurodivergence would be. The other question is, can you suggest a few home-based training techniques?
Yeah, so like I mentioned in the beginning, to start stimulation, I mean, there are many kids, many parents, who say, we ask them generally, child is 3 years, what kind of toys have you given? What do you do with the child? So many a times we realize that they've done nothing. I mean, they've just shown the screen, or they've, not spent like one-to-one time, floor time, as we call it, or give them normal pegboards, give them normal clay. So we at least introduce these. I don't think you need a lot of toys. You can do your normal kitchen stuff also and start with therapy. Help them to, increase their sitting tolerance. So we sometimes overstimulate our kids. We give them a lot of toys, a lot of things around, and that overstimulates the child. So keep only one toy available for the child. You play with the child for half an hour, teach the child to reach out for what he wants. Very basic things like this. Deep pressure massage. So we train our parents, the whole gym ball, we train them how to do deep pressure massage with the ball. I think that helps a lot with things like hyperactivity or aggression, or teaching them some strategies where they can manage these aggressive kids at home. I think these are kind of part of the home program that we do with the parents.
I must let you know, Pallavi Rakne Singh has always a masterclass presentation. So congratulations to you. And looking at other questions that are there, I think we've covered most of them. Will the recording be uploaded? Yes, Abhijit has told us it will be on the website of IPS. Am I right, Abhijit? I think he said that.
He may not be there, but yes, it will be on the IPS, the West Zone website. Yes.
Yes, Pallavi is saying yes. So I think we've covered then most of the questions that are there. So thank you, Manjari, again once more for a very comprehensive and a wonderful presentation. Abhijit is saying yes, and also on the YouTube channel. So don't forget to subscribe to the West Zone YouTube channel. Okay, guys, you can get a lot of information over there. Okay, Ipsita is saying one more question. So if a child is repeating things from TV, why do you say it doesn't have speech development? Manjari.
So it's more repetitive speech. We are looking at communication for the child. So children will, there are kids who will repeat an entire story or an entire song. We want them to start with communication. And we try to ask the parent, like, rather than having them to learn. So we have parents who focus on, okay, learn the A to Z, learn numbers, learn tables. But first thing is start teaching them to communicate. So that's where the difference comes from. And that's what we start, whether the child can first non-verbally communicate and then communicate his basic needs, then go on to reciprocal communication.
And if I may just add that it's not necessary the aim for every child is to become verbal.
Yes.
The aim for every child is to be able to communicate his needs and be able to express or let us know in some way what is happening. So whether we do picture exchange, which is also working beautifully, or whether we go to, sign language, or whether we actually have communication, depends on the child and, how severe and what are the issues that are involved with it.
We
So
have a lot of non-verbal children
Yeah.
who communicate very beautifully through
Yeah.
stories, through flashcards, through texts.
So there is a lot that can happen. So I think trying to reverse the symptoms, like I have a lot of parents say, when will he start eye contact? It's not important that they have to have eye contact. They have to be able to do things independently. They have to be able to, be able to communicate. We're looking at all of that, not reversing what were the symptoms that were originally there. So keep that in mind also. Oh, I think we should really call it a day. It's been a wonderful
Yes.
evening with so much interesting material being discussed. Thank you, Manjuri, and I hand it over to Nilima to
Thank
take
you,
it
ma'am.
ahead.
Thank you so much.
Thank you, Dr. Manjri. Thank you, Dr. Heenal, for the concluding remarks as well. Now I request Dr. Ritamra ma'am to say the vote of thanks.
Is Dr. Abhijit there? Does he want to do it, or I will do it? He's not there.
I don't think he's there, ma'am.
He's
Okay,
there, he's there,
okay.
he's there.
He's there?
He at
He
least
did
message
say,
in
he
between.
did respond for some time.
All right, go ahead.
It's okay. Like, yeah, again, I'm reiterating that Dr. Manjari, it was wonderful. And Dr. Heenal, thank you very much. As an expert, you have really carried it well, and you have responded to all the questions that were asked. And it was very, very informative. And I hope that it motivates everyone to actually work in the field. And actually, it's not enough, because there's so much more we can do. As you said, there has to be so many more centers and more accessibility for poor patients, maybe free access to all kinds of facilities. Is actually, as Madam, I forget her name, from USA, she also gave
Sandhya,
very, very nice inputs. Thank you, Madam. And all the audience, and I can see, I mean, we reached more than 55 figure. That's wonderful. And it was the first webinar, and Dr. Bhave and Dr. Abhijit also joined. And of course, can all of us, like our subcommittee, can you all show your faces, please?
Well,
I think we never took a photo. So, madam is yeah. All of
If
y'all,
all
if
of
y'all
you
can
can
put on the
actually,
video, we
yeah,
can have a photo.
yes, Dr. Nilima, Swati, Neha, I saw them. Alapi is also there. Akshada is not there as such. Khyati, all of you, can you all come? I mean, is there a mode which needs to be changed, Nilima, or we can see all the photographs?
We can see, ma'am.
Yeah. Nobody wants to show the face, is it?
Some of them have put pictures, I think, but
Hmm. Really? Hmm. No, but I can see only two. Maybe some mode we can change.
ma'am,
Some
on
of
the
the.
right upper corner from view, you have to change to
Gallery
gallery
view.
view. You have to
Hmm.
change to gallery view, ma'am.
Gallery.
Don't know about everyone. Dr. Khyati is already in Goa. Or probably Andaman and Nicobar. It looks better than Goa. Or maybe Lakshadweep.
Okay, I have
Swati, Dr. Swati is not visible due to the lighting, I think.
yeah.
Maybe you can set the lighting and then we can take a pic.
I have to join from the mobile because this camera is spoiled, so I will join. But I think this will be okay then.
Okay.
It is
Yeah,
little
fine,
noisy,
fine.
but it's okay.
all right. I have taken a screenshot.
That's
Somebody
great.
else take one also.
All smile, all smile. Yes, the cheese. Yeah, it's a great beginning, and I'm sure the whole team will be keeping us busy all throughout the year. Every month, a program, and one for child and adolescent, and one for women. Yeah, that's great. Yes.